So today we'll be testing the range of motion of shoulder flexion. To do this, I'm going to have my patient lie hook line with his feet up. If you please extend your feet up, both right there, both the same. Perfect. So our fulcrum placement is going to be on the acromion process. If you want to palpate that right there. Our stationary arm is going to be parallel with the sternum or the midline of the body. Just to test out, see if he has the range of motion. I'm going to this come back. Perfect. I'm going to get my measurements. Go ahead if you could flex one. So the acromion process disappears here. So we're going to go from the axis of motion. So same thing, stationary arm down the side of the body, axis of motion. And my patient has 175 degrees of shoulder flexion, which would be normal. The normal limits of shoulder flexion are between 150 and 180. Next, we're going to be doing the range of motion test for shoulder extension. This test, the patient is going to extend his arm, like so. The fulcrum placement, again, is the one before on the acromion process. This one you'll actually be able to see the whole time. Stationary arm is going to stay, midline of the body, and I'm going to ask him to please extend. Finding that point again. Back up. My patient has about 40 degrees of shoulder extension, which would be considered normal. Next, we'll be doing the range of motion test for shoulder abduction. The motion for this test is my client or patient is going to abduct his arm this way, as far as he possibly can, and then back. So the range of motion placements for this, the fulcrum is going to be on the acromion process. You can palpate it fairly easily in this position. The stationary arm, instead of the midline, it's actually going to be parallel to the sternum. So if you can abduct for me, I'll let him extend. The same thing, we're going to go from the axis of motion. Again, my stationary arm parallel to the sternum. And coming out. My patient has 170 degrees of abduction, which would be considered normal.
So now we're going to complete external rotation at the shoulder joint. Have the patient lay in the supine position with their arm on top of a towel to support the elbow and at a 90-degree angle. External rotation, we're going to have the patient move his arm in this plane, in the sagittal plane. Our fulcrum for this is going to be on the olecranon of the ulna. Our stationary arm will be perpendicular with the floor, and our movable arm we will line up with the styloid process of the ulna. So I will now ask my patient to externally rotate. And in lining up, we have a range of motion of 79, which is in the normal range of motion for external rotation of 70 to 90 degrees. Now we will complete internal rotation of the shoulder joint. So to start, like external rotation, we will have our patient laying in the supine position with a towel supporting their arm. Once again, our fulcrum will be on the olecranon process of the elbow. Our movable arm will be with the styloid process of the ulna, and our stationary arm will be perpendicular to the floor. So I'll ask my patient to internally rotate as far as they can. We have a range of motion of 92 degrees, which is above the normal range of motion of 70 to 90.
Our first manual muscle test is going to assess the flexion at the shoulder joint. So first I'm going to have my patient go through the range of motion in a semi-pronated hand position. Have my patient return to 90 degrees at the shoulder. I'm going to stabilize the ipsilateral shoulder, palpate at the distal humerus, and apply resistance in the shoulder extension direction while my patient resists. My patient has a grade 5 normal strength against resistance. Next manual muscle test, our patient will be in lateral position and we are going to assess shoulder flexion. So I'm going to stabilize at the ipsilateral shoulder and have my patient go through the range of motion. And he is normal range of motion. Next, we will be assessing shoulder extension, manual muscle testing. My patient is going to be in a prone position with a towel. He's going to have both of his arms internally rotated with palms up, and he's going to go through the range of motion. Next, I'm going to stabilize the ipsilateral thorax, apply resistance to the distal humerus in the direction of shoulder flexion, and have my patient resist. My patient has normal strength against resistance, which is a grade 5. Next, we will be assessing manual muscle testing for shoulder extension. Our patient is going to be in a lateral position. He's going to have his assessed arm on a towel on a low friction surface. I'm going to stabilize the ipsilateral shoulder and have my patient go through a shoulder extension. Which seems normal. Next, we'll be assessing manual muscle testing for shoulder abduction. My patient is going to be seated. First, we're going to go through range of motion. The patient is going to hold it at 90 degrees. I'm going to stabilize at the ipsilateral shoulder, apply resistance to the distal humerus in direction of adduction, and have my patient resist. My patient has a normal strength against resistance, which is a grade 5. Next, we will be assessing manual muscle testing for shoulder abduction. My patient is going to be supine. I'm going to have my patient go through the range of motion up until 90 degrees, have him return to neutral position. I'm going to stabilize the ipsilateral shoulder, palpate the medial deltoid, and have my patient go through the range of motion. Which seems normal. Next, we will be assessing manual muscle testing in the scapular plane of shoulder abduction. I will first palpate the supraspinatus. My patient's going to have his thumb up, and he's going to go through the range of motion. Next, I will stabilize the ipsilateral shoulder, have my patient return to 90 degrees, apply resistance to the distal humerus in the direction of shoulder adduction. My patient has normal strength against resistance, which is a grade 5. Next, we'll be assessing shoulder internal rotation, manual muscle testing. My patient will be in prone position with a towel under his head. His face is going to be turned to the contralateral side of the assessed arm. His humerus will be resting on a towel. His elbow will be bent at 90 degrees. I'm going to first have him go through the range of motion slowly. Next, I'm going to palpate the supraspinatus and stabilize the ipsilateral shoulder. I'm going to palpate the distal wrist and apply resistance in the direction of external rotation. My patient is normal strength against resistance, which is a grade 5. Next is manual muscle testing for shoulder internal rotation, gravity eliminated. My patient is going to be in a prone position. His face is going to be turned to the contralateral side. His upper extremity is going to be completely hanging off the table. And I'm first going to assess range of motion. Next, I'm going to stabilize the ipsilateral shoulder and palpate the subscapularis while my patient goes through this range of motion. Which is normal. Next, we will be assessing shoulder external rotation, manual muscle testing. My patient will be in prone. His head will be turned to the contralateral side. His shoulder and elbow will both be at 90 degrees. His humerus will be resting on a towel. I'm going to first assess the range of motion. Next, I'm going to stabilize the ipsilateral thorax and palpate the infraspinatus. I'm going to apply resistance in the direction of internal rotation while palpating the proximal wrist. My patient has normal strength against resistance, which is a grade 5. Next, we will be assessing shoulder external rotation, gravity eliminated. My patient will be in the same position, which is prone. His head is going to be turned to the contralateral side. He's going to first show me that he has adequate range of motion. Next, I'm going to palpate the infraspinatus and stabilize the ipsilateral shoulder, while I also palpate the subscapularis and have my patient go through range of motion. External rotation is normal. Next, we'll be assessing shoulder horizontal abduction. My patient will be in the supine position with a towel under his head. First, to assess range of motion, my patient's shoulder and elbow are going to be at 90 degrees. He's going to hold a fist. I'm going to palpate his pectoralis major while I assist in the range of motion. Next, I'm going to stabilize the ipsilateral shoulder. I'm going to apply resistance in the direction of horizontal abduction. The patient has normal strength against resistance, which is a grade 5. Next, we will be assessing shoulder horizontal abduction, gravity eliminated. My patient is going to be seated with his shoulder and elbow joint at 90 degrees, and which is rested on a table. I'm going to palpate the pectoralis major and assess the range of motion, which appears normal.
So now we'll be doing a manual muscle test through scapular elevation, gravity resisted. I'll have my patient in a seated position. I will bring them to the range of motion. Now I'll ask them to turn their head to the opposite side. I'll palpate the trapezius and have them do the same. Finally, I will have them elevate, and now I will palpate their occipital bone and apply resistance in a lateral anterior direction. Perfect. My patient is normal. So now we'll be doing a gravity eliminated position for scapular elevation. I'll have my patient lie prone with their head facing forward. I will ask my patient to elevate their scapula to bring them to the range of motion. And now I will palpate the trapezius muscle and do the same. My patient appears to be normal. Now we'll be doing a manual muscle test for scapular abduction and upward rotation. I'll have my patient seated without back support. I will have them go through the range of motion. After doing that, I will palpate the ipsilateral shoulder and the serratus anterior and have them repeat. I noticed how the scapula did outward rotation. Now I will apply resistance to the distal humerus and also the lower portion of the scapula. And when I do this, I will be pushing inward in the scapula and down on the humerus. Ready? Perfect. My patient is normal in grade 5. Now we'll be doing a manual muscle test for scapular adduction and downward rotation. I'll have my patient lay prone on the table, their face facing the opposite side. I will have them bring their hand on top of their gluteal region, and I will stand on the contralateral side. While I have them go through the motion, I will palpate the rhomboid area. So what I'll ask him to do is bring his hand up off his gluteus muscle and back down. Now when I apply resistance, I'm going to be applying it to the medial scapula in a direction of abduction and outward rotation. Ready? Perfect. My patient is grade 5 and normal. Now we'll be doing a manual muscle test for scapular adduction and downward rotation. My patient is going to be in a gravity eliminated position, which is the seated position. I'll have them bring their hand behind their back towards their gluteal region. And what we'll be doing is I'll be palpating the rhomboids muscles as they go through the motion. Perfect. Now I'll be applying resistance, and the resistance will be on the medial scapula in an abduction, direction, and as well as an upward rotation. Perfect. My patient is grade 5 and normal. Finally, we'll be doing a manual muscle test of scapular adduction and depression. I'll have my patient lying prone with their head facing the opposite direction. To start, I will bring them through the range of motion, up to 120 degrees. Next, I will palpate the contralateral thorax near the ipsilateral shoulder and apply palpation near the lower trapezius as they go through the motion again. Finally, I will be resisting in an abduction and elevated direction as they try to go through the motion again. Go for it. Perfect. My patient is grade 5 and normal.
So one common injury seen in the shoulder joint is what's called a shoulder subluxation. A subluxation just means a partial dislocation. This is more common in tall, thin men, and it can be spontaneous. Now the way it's fixed is two ways. It's either, actually three ways. It's either self-reduced, reduced by a physician, or requires surgical intervention. Now depending on how much pain the patient is in and whether our patient is guarding, that is resisting the physician's reduction, that determines whether it can be fixed with or without anesthesia under surgery.